Hello, and thanks for joining me for my third video in this series about migraine. I'm Christina Lindemann, a PA specializing in neurology at UC San Diego Health. And in this video, we are going to talk more about the diagnosis of migraine. In the last video, we talked about some of the things that might lead us to suspect a patient is experiencing migraine. Our next step is to make sure we have a thorough patient evaluation, which includes a headache history, as well as a physical exam. In my headache history, I ask a number of questions to understand the pattern of the headaches, such as the onset, duration of attacks, and triggers for the headaches. I also ask about associated symptoms, the severity of their pain, their medical history, their treatment history, and their family and social history. This conversation can take a while, but the details are important. My physical exam typically includes vitals, a neurological exam, including a fundoscopic exam, an assessment for reproducible triggers of pain through palpation of different areas on the head, evaluation of the jaw, and evaluation of the neck. The neurological exam should usually be normal in migraine. On the topic of patient evaluation, let's talk about the official diagnostic criteria for migraine and differentiating between types of migraine. We use the International Classification of Headache Disorders 3rd edition, or ICHD-3, to do this. One specific differentiation in migraine is migraine with aura and migraine without aura. Migraine without aura is characterized by a history of 5 or more migraine attacks, with headaches lasting 4 to 72 hours when left untreated or unsuccessfully treated. They must also have at least 2 of the following: unilateral location, pulsating quality, moderate or severe pain intensity, and aggravation by or causing avoidance of routine physical activity. During the headache phase, patients must experience sensitivity to light and sound, or experience nausea or vomiting. Finally, their diagnosis cannot be better accounted for by another ICHD-3 diagnosis. Migraine with aura is characterized by a history of at least 2 migraine attacks, with the presence of at least one of the following categories of fully reversible aura symptoms: visual, sensory, speech or language, motor, brainstem, or retinal. For a diagnosis of migraine with aura, the patient must also experience at least 3 of the following: 1 aura symptom that spreads gradually over 5 or more minutes, 2 or more aura symptoms that occur in succession, such as a visual aura followed by a sensory aura, each individual aura symptom lasting 5 to 60 minutes, at least 1 aura symptom that is unilateral, at least 1 aura symptom that is positive, such as tingling on one side of the body or scintillations in the vision, or the aura must be accompanied by or followed within 60 minutes by a headache. Finally, for diagnosis, the symptoms cannot be better accounted for by a different ICHD-3 diagnosis. Since auras can mimic other neurological conditions, such as a stroke or transient ischemic attack, it is also important to rule these out through a thorough history and appropriate additional evaluation depending on the clinical presentation. Finally, let's talk about a diagnosis of chronic migraine. This is differentiated from episodic migraine by attack frequency. Chronic migraine is characterized by at least 15 migraine-like or tension type-like headache days per month for more than 3 months. On 8 of these days, patients must also experience at least one of the following: features of migraine without aura, features of migraine with aura, or an attack believed to be migraine at onset that was relieved by appropriate medication including a triptan or ergot derivative. As with other diagnoses, the symptoms cannot be better accounted for by another diagnosis. Keep in mind, patients may underreport or underestimate their headache frequency, only focusing on the more severe headache days. I often specifically ask my patients about the number of headache-free, completely clear days that they are having to help better differentiate their symptom frequency. As you've seen, the diagnostic criteria for our different types of migraine note that symptoms should not be better accounted for by another ICHD-3 diagnosis. This includes exclusion of secondary headache disorders. One way to screen for secondary headache disorders is through the SNOOP-4 or SNOOP-10 mnemonic. These can help find red flags that further evaluation is needed or that there are other contributory causes to the headache presentation. Occasionally, neural imaging is used when there's suspicion for a secondary headache disorder, but is generally not recommended for migraine as a primary headache disorder. When I diagnose a patient with migraine, I work closely with them to help explain their disorder, help them identify patterns and triggers, and make decisions regarding their treatment. We act as a team on this journey and have transparent discussions so that we can tailor their care to their needs. In my next video, I'm going to discuss some treatment options, goals of treatment, and how we can educate our patients to help them achieve a life with less pain. See you there.